Welcome to all of you. For those who don't know me, I'm Karen Davis, the Eugene and Mildred Lippitz Professor of Health Policy and Management here at the Johns Hopkins Bloomberg School of Public Health. So we appreciate your being here. We welcome those who are listening in online to this session. We'll also be taping the session and available for use in courses and others who are interested. This is the latest in a series of Johns Hopkins Bloomberg Centennial Health Policy series of forums. We're very grateful for the gift of Frances Hankel, a graduate from 1985, whose generous gift to the Centennial Policy Scholar and Symposium series is made possible. So thanks to all of you, but particularly we're delighted to have a very distinguished panel with us today to join in discussing the Affordable Care Act at 6. Today is officially the 6th anniversary of the Affordable Care Act, looking at its impact as well as next steps. A lot of dire predictions surrounded enactment of the Affordable Care Act 6 years ago, and there's continued to be a lot of criticism and allegations about what would happen and has happened to the affordability of health insurance, access to care, quality of care, impact on seniors, impact on the economy, on jobs, on business, impact on the federal and state budgets. And it's been a bit of a surprise to me that this controversy continues and that we've had, in fact, repeated calls to repeal the Affordable Care Act, including most recently one that passed the Congress but was vetoed by President Obama. So it's really a good time to take stock of what the early evidence shows on the ways in which the Affordable Care Act is affecting the way that Americans obtain health insurance, the way they obtain health care. Today, President Obama issued a statement on the 6th anniversary of the Affordable Care Act. The White House put out a fact sheet of how they see the impact of the act. I think as scholars, all of us know that it's hard when you don't have a randomized controlled trial in public policy to know what would have happened 6 years, even if the Affordable Care Act hadn't been enacted. But we do know what was happening before it got enacted, and namely that the numbers of uninsured were rising from 38 million at the turn of the century to 48 million by 2010. We know that health insurance premiums were going up at double-digit rates, very rapid growth in healthcare expenditures. So as you listen to some of the early evidence, you should put it in the context of where the path we were on versus the path that we've changed to. The other difficulty when you don't have a randomized controlled trial is knowing how to disentangle the effects of different things. I was a little bit amused, I confess, when President Obama in his statement said that the unemployment rate had gone down from 10% to 5%. And I think that's good for his track record of his administration, but I don't think we all think that was strictly because of the Affordable Care Act, but obviously were economic forces following the Great Recession, which he inherited, that have taken a long time to turn around the economy. But I think what it does show is that the dire predictions that the Affordable Care Act would lead to massive job losses, business failures, we've not seen that. In fact, we have seen the return of a vibrant economy. Certainly, the other thing that was interesting in the White House fact sheet was pointing to the savings to the federal budget from what had been projected primarily in the Medicare program over time, and documenting $500 million in reduced federal outlays, again attributing it perhaps all to the Affordable Care Act, maybe a portion of it to the Affordable Care Act, but certainly refuting predictions that the Affordable Care Act would drive up the deficit, be unaffordable to taxpayers. In fact, we've seen significant savings to federal programs since its enactment. So we're really fortunate to have an outstanding set of experts with us today to help us sort through what the early evidence shows, particularly focusing on access to care and affordability of health insurance and health care, and what we've seen to date. We're going to start with Dr. David Blumenthal, who's the president of the Commonwealth Fund. Terrific organization, nonprofit organization committed to helping achieve a high-performance health system. Dr. Blumenthal has had a distinguished career. You've got his bio on the back of the program. He served President Obama for the first 2 years of his administration as the director of the National Coordinator for Health Information Technology, or wiring the healthcare system. He was professor of medicine, the Samuel Thier Professor of Medicine at Harvard Medical School. He was at the Massachusetts General Hospital, where he directed the James Mongan Institute on Health Research and Policy. He has written a book on presidents and health policy. He visited the presidential libraries of all of the previous presidents since Franklin Roosevelt, and really went to the source, so expressing his keen interest in history and politics. So we're going to lead off with him, and then we're going to have a panel which will include Congressman Henry Waxman. I hope you've been able to make some of the prior series. He is the Johns Hopkins Bloomberg's School of Public Health Centennial Policy Scholar, so we're very honored to have him in that position. I think most of you know that he served the U.S. House of Representatives for 40 years, chairing the Energy and Commerce Committee, which was one of the major committees dealing with a range of health issues, but also centrally involved in shaping and enacting the Affordable Care Act. I always find it a little bit of music that this law is referred to, mostly by its detractors, but referred to popularly as Obamacare. And having watched it been formed, I thought there are so many leaders of Congress, like Congressman Waxman, like then Speaker of the House Nancy Pelosi, who really, without their leadership skills and legislative skills, I do not think we would have had the Affordable Care Act. It was just a very close, contentious fight, as it has continued to be. But on the panel, I'm delighted that we'll be joined by Michael Hash. He was director of the Office of Health Reform at the U.S. Department of Health and Human Services from 2011 to 2014, and before that had been the from 2009 to 2011, had been the deputy director at the White House Office of Health Reform. So he was very key in the administration as the legislation was being shaped, and certainly at the department as the law was being implemented. Again, a very distinguished career. He's been a principal at the firm Health Policy Alternatives, but he had also been within the department in the late 90s as the deputy administrator of what was then called the Healthcare Financing Administration, HCFA, and then was the acting administration for what is now administrator for what is now CMS. Maybe particularly for this panel, I should point out, he was also the senior policy advisor on the Health and Energy Subcommittee, Health and Environment Subcommittee of Energy and Commerce, and worked for Congressman Waxman. And then we're also going to be joined, and this is a special pleasure, by Karen Nelson, who never agrees to do this sort of thing. but Dr. Sharfstein sent her an email that had 5 words in it. Please, 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 please. Maybe one word repeated 5 times. So I think that also had something to do with her decision to be with us today. Again, very distinguished career in the Congress as staffer, starting with the Senate Finance Committee, which some of us forget because she spent so many years at the Energy and Commerce Committee as staff director for the Health and Environment Subcommittee, and then deputy staff director for the full Committee on Energy and Commerce when Congressman Waxman moved up to chair that. So those very distinguished panelists will kick off with some remarks when we turn to the panel. We're also fortunate to convince our Associate Dean, who I assume needs very little introduction to this audience, who will moderate the panel. But those of you who don't know, Dr. Sharfstein, he was formerly Secretary of Health and Mental Hygiene for the state of Maryland, so has a very interesting perspective on the Affordable Care Act and how it affected the states. He was the Principal Deputy Director of the Food and Drug Administration, and at one point in his past was a health policy advisor of Congressman Waxman. So I think you see a certain theme here. I always like to point out that he's a pediatrician, because I always give pediatricians a lot of credit for having a lot of heart. So it's going to make up for a great panel. But with that, I'm going to turn it over to Dr. Blumenthal.
So can you hear me? So thank you, Karen, and it's really a pleasure to be here at this event to participate in the 100th anniversary of the Hopkins School of Public Health. Having spent most of my career at Harvard, I have a healthy respect for Hopkins, and I think we're all in the same business, though we do occasionally compete in a very constructive way. And it's also a pleasure to be part of this panel, surrounded by Congressman Waxman and his former staff members. Having worked for Senator Kennedy on the other side of the Capitol and done business in conferring with, that's a neutral term, conferring with Congressman Waxman's staff, I also appreciate the friendly rivalry that goes on between the two houses of the U.S. Congress. So I'm going to talk a little bit about where we are with the Affordable Care Act since it's been enacted. This is the 6th anniversary today of its enactment. And before that, I'd like to make just a couple of basic contextual points. The Affordable Care Act is the culmination of 80 years of controversy about covering Americans for the cost of illness, starting really with seriously with Franklin D. Roosevelt's administration, working through Medicare and Medicaid in 1965, and then through the effort by President Clinton to pass a comprehensive plan that, of course, failed. And this piece of legislation is a revival of that effort and the controversy surrounding it. And one can actually see in its provisions accommodations to the failures of the past, the efforts to do things that were more comprehensive, and a reckoning with the politically possible. And many of the criticisms, and there are many and they are justified, of the Affordable Care Act in terms of its limitations, the things it hasn't done, things it does do, the way it does them, can be explained and have to be seen in the context of that 80-year struggle, most of which went unrealized. It was actually the first, in President Obama's campaign, was the first time that a Democrat since Clinton had forcefully advocated for universal coverage in kind of on the rebound, the penalty that was paid for the failed Clinton effort. So that's just by way of controversy. We see controversy now in the current, on the Democratic side of the election around the same issues, and understanding that tension, I think, is important as you look at the Affordable Care Act. So what's happened since the Affordable Care Act was enacted? Well, as Karen mentioned, one of the things that's happened is that a lot of people have gotten health insurance. The numbers of uninsured Americans peaked at almost 50 million at the height of the recession in 2010, and it's now down about 20 million. 20 to 21 million is the current estimate based on multiple federal surveys and multiple private surveys of the numbers of people who gained insurance since 2010. That's a pretty dramatic change in the profile of America's insurance coverage, and one that is almost certainly attributable to the influence of the Affordable Care Act. In keeping with that, another thing that we have seen is the reduction in cost-related barriers to access to care as reported in surveys of Americans. So these are data on the proportion of Americans of all ages who reported that cost prevented them from getting care in the previous year. And you can see it went from a peak of about nearly 7% to about 4.6% in 2015. So again, a tangible effect of having insurance coverage. If you look across the spectrum of people who have been touched, affected by the Affordable Care Act, the number exceeds the 21 million who have gained insurance. It includes about 2.5 million young Americans under the age of 26 who have gained coverage through their parents' plans as a result of a requirement by the Affordable Care Act that that coverage be made available. It includes about 12.7 million people who are insured through the marketplaces. 8.8 million of those are going to have an estimated effective insurance, that is, they'll be paying their premiums on a regular basis. 14 million Americans are newly enrolled in Medicaid. You sum that up, you get close to 30 million who are working with or being affected by the provisions of the Affordable Care Act. Most people who have insurance, either through the federal marketplaces or the Medicaid program, are satisfied or very satisfied with their insurance. So 45% are somewhat satisfied, 40% are very satisfied. That is a kind of bottom line reflection of the perception of the law and its coverage by those who are most directly affected. This includes and accounts for all the complaints about narrow networks, and the limitations on coverage, which are substantial. In both narrow networks and, as we'll see, deductibles and other copays, are limitations in generosity and capability of the new insurance. One thing that has emerged, and this is Commonwealth Fund's work that I'm sharing with you now, is that among those who have coverage and have used it, 62% said that it has made the difference between their getting care and not getting care. So these are people who are getting access to care through the insurance who would not have been able to get access to that care before they had insurance. Narrow networks are a problem, not for the majority of people who have insurance, but they do affect a minority of people. Some are in very narrow networks, about 22% in the yellow wedge of this pie chart. Some are in ultra narrow networks. 55%, the majority, are not perceive themselves as being limited by networks in terms of the extent of their coverage. But it is a phenomenon that we are dealing with, and perhaps if people are interested, we can talk more about that in the question and answers. The people tend to be satisfied with the doctors that they are covered for. So even though networks are narrow, the majority of people are somewhat or very satisfied, 90%, with the availability of physicians. Even if networks are narrow, they may still include, in those narrow networks, the physicians and nurses and others who the individuals who are insured wish to see. So narrow networks are not always an inhibition to getting care from those that you wish to get care from. Now, deductibles are a pervasive problem in our healthcare system for insurance right now. If you look at the proportion of the group of bar charts at the far left, the proportion of privately insured adults, working age adults who have no deductible has gone from 2003 to 2014 from 40% to 25%. If you look at the far right-hand side, the proportion who've gone from not having a deductible of $3,000 or more to having one has gone from 1% to 11%. $3,000 probably exceeds the savings of most Americans. These are prescriptions for inadequate insurance. This is not confined to people in the marketplaces. It's universal in employer coverage and in private insurance generally in the United States. But it does affect people who are getting marketplace coverage and somewhat more than people who are not getting who are getting employer coverage. So this is a rather complicated slide. If you look at the very top bars, you'll see that among all adults, those who have marketplace coverage are somewhat more likely to have large deductibles than people who have employer-based coverage. That's the blue on the far right. 43% of those with marketplace coverage are likely to have a deductible of $1,000 or more compared to 34% of those with employment-based coverage. If you have an income of 250% of poverty or less, you are entitled to cost-sharing subsidies through the Affordable Care Act. So some of those deductibles are no longer as penalizing as they are for employed Americans. But it is still a fact that that marketplace coverage, especially for moderate income Americans, tends to have higher deductibles and higher copays. A lot of people are eligible to be covered through the marketplaces and through Medicaid who are not getting coverage. So if you look at those who are uninsured in 2015, non-elderly uninsured, you look at who is eligible, and you'll see that about 28% of the uninsured are eligible for Medicaid and not being covered, and about 22% are eligible for subsidized premiums and are not taking advantage of that. So there's a lot of potential for the law to cover more individuals than it is covering, and why they are not getting coverage is an interesting question that deserves further attention. Now, I was asked to talk a little bit about the plans that are under consideration or being proposed by candidates for office. I couldn't cover everybody, so I covered the folks who are leading candidates, and we can talk about others if there's time and interest. But between Secretary Clinton and Donald Trump, there is a lot of difference, and I'll go down through a couple of those, a couple of the areas where the provisions are especially different. First of all, in terms of overall approach, Secretary Clinton is intending to build on the Affordable Care Act, whereas Donald Trump has advocated repealing and replacing it. Secretary Clinton advocates the coverage of all Americans for the cost of illness through insurance. Donald Trump does not do so. Secretary Clinton would expand the coverage available under the Affordable Care Act through letting, for example, undocumented Americans purchase marketplace coverage. She also advocates a vigorous enrollment campaign of about $500 million a year to encourage enrollment in the marketplaces and in Medicaid. Donald Trump does advocate selling insurance across state lines, which is a fairly characteristic Republican proposal for expanding access. Secretary Clinton has proposed adding public options at the state level by encouraging states to do that. Obviously, Donald Trump repealing the ACA would not have that on his agenda. Secretary Clinton supports letting states that adopt Medicaid later still have the benefit of 3 years of 100% Medicaid matching. That is, having the federal government pay the full cost of Medicaid for 3 years after the adoption of Medicaid, the expansion of Medicaid, regardless of the timing of that. Donald Trump would change Medicaid into a block-granted program. It is estimated that there would be a further decrease in the numbers of uninsured under a Clinton plan, an increase of about 21 million in the levels of uninsurance under a Trump plan. Both plans would lead to some increase in federal costs. I shouldn't really call them plans. They're not plans. They're a set of ideas, and I'll leave it at that. I'm not going to go through all these additional provisions. I suspect that the slides will be available to you. I do think it's worth noting at the very bottom that Secretary Clinton continues a long-term interest on her part in delivery system reform and has embraced a lot of the ACA, Affordable Care Act related provisions that have to do with that. Donald Trump doesn't speak much to that, but he does talk about price transparency. One of the things that's worth noting is that, though it's not clear whether he still supports it, Donald Trump has advocated for Medicare negotiating drug prices with pharmaceutical companies. This, I'm sure, was something of a surprise to his Republican counterparts. Secretary Clinton also embraces that strategy. I have a feeling, though, that Donald Trump is no longer quite such a strong supporter of that position as he once was. So I'm going to stop there and let my colleagues, I guess, come up to the table at this point, and thanks for your attention.
Thank you very much, Professor Davis, Dr. Blumenthal. That was great. Thanks, everybody, for coming and watching online as we get situated. We're going to have a little bit of a discussion, then open for questions. So everybody can start thinking about that. I'm going to start by turning to Mike Hash to talk about the private insurance markets in the Affordable Care Act. And I knew Mike when I was working in the state, and he was the face of the HHS team working with states to support implementation of the Affordable Care Act. And I'm very interested in what he has to say. And I guess both in your perspective on where things stand now, but I'd be interested in what you'd say about what you expected, what you didn't expect, and what you think looking forward. Thank you.
Okay, thanks, Josh. It's also a pleasure to have a chance to come and talk about the Affordable Care Act with all of you on this, the 6th anniversary of its enactment. So it's a happy day for those of us who participated, had the privilege of participating in that process. To me, I think, and I want to do this very briefly, the most helpful thing might be to give you a little context about the individual and small group insurance market prior to the Affordable Care Act, and then talk a little bit about how that marketplace has been changed by the provisions of the Affordable Care Act. You've already heard from David and others and Karen about the state of affairs prior to 2014 and the beginning implementation of the Act. And I think it's fair to say that with respect to the individual and small group insurance marketplace, those markets were really not functioning. They were characterized by excluding people based on pre-existing health conditions, based on gender, based on other health status factors. They were also, those marketplaces also offered plans that were, for many people, if they could access them, were unaffordable. They really also weren't a very good value to people because upwards of 40, maybe 50% of the premium dollar actually went to overhead expenses, not to pay for healthcare services. So for those and many other reasons, limitations in the coverage that was available through the individual and small group market were really the focus of much of what the marketplace reforms were in the Affordable Care Act. Some of you may also be aware that once the act was passed, there were some so-called early deliverables, things that were kind of high priority to be put in place right away. Things like prohibiting annual and lifetime limits on the coverage of individual and small group policies, as well as large group policies, getting rid of any pre-existing condition exclusions for children's coverage, coverage of, as David mentioned, children on their parents' policies up to age 26, and then two other very important sort of preliminary efforts to reform the marketplaces: a pre-existing condition insurance temporary risk pool that provided access right away to people who had been locked out of those two markets, and also a program to subsidize more fully retiree health insurance between the ages of 55 and 65, a marketplace where coverage for retirees had been declining precipitously. And lastly, not unimportant, to put into place right away a standard for the value of health insurance in individual and small group market of 80 and 85% of the premium dollar of policies sold in those marketplaces had to be for covered services and not for overhead. So once those early reforms were put into place, beginning, of course, in late 2013, the marketplaces, these new places to access individual and small group coverage, began to be implemented. And as I'm sure you all know, we had a bit of a rocky start. The websites for the federal program, which was really being run in 38 states, did not function properly or adequately in the beginning. It took several months to make it work appropriately. And actually, in some of the states, similar problems occurred. Some states that ran their own marketplaces were quite successful from the very beginning. So it's kind of a mixed initial response. But once things got up and running, the new marketplaces really offered coverage that was affordable, that lacked limitations that were characteristic of the marketplace beforehand. And I think most importantly in this new marketplace for the individuals who had incomes below 400% of the federal poverty line, there were tax credits available to help offset the cost of that coverage. And for people of particularly low incomes below 250% of poverty, there were cost-sharing protections that were significant in reducing the risk for out-of-pocket expenses for covered benefits. I think I'm going to close by just saying a couple of things about what I think are the challenges that continue to face these marketplaces. First, there's a big question about, I think in some of the state-operated programs around the state-operated marketplaces, whether they can really remain financially viable, can be self-sustaining, can raise the necessary funds to maintain the operations of these marketplaces. And we can talk more about that, but that's a serious challenge in a number of states. There's also an issue about being able to continue making payments to insurance companies to help offset early experience with the risk pool. This is kind of an arcane thing, but it's a set of policies designed to help insurance companies cope with a risk selection pool that's particularly slanted toward people with higher healthcare needs. There's also an issue about making, in the future, insurance coverage in the workplace, employment-based coverage, more accessible to people by taking account of the entire household income as a basis for whether people qualify for affordable health coverage versus just looking at whether the coverage for an individual worker is affordable to them. And that's a very serious barrier for some families. Two more points. Competition in some of these new marketplaces is not as robust as people would like to see it. There are still marketplaces where there's a dominant insurer who may actually be selling coverage to more than 60, 70, 80% of the marketplace. And that's obviously not a situation that's conducive to robust competition. And then lastly, again, David alluded to this in his remarks, the issue of delivery system reform in terms of continuing to moderate the increasing cost of healthcare and also improving the quality of healthcare that's available not only to people in the individual and small group, but for all Americans who are using our healthcare delivery system. So, Josh, I think that's about what I would say is an opening gambit about how we got to where we are and sort of some of the big remaining challenges facing implementation of the Affordable Care Act.
Great, thanks so much. I think to a certain extent you got the short straw because that's not so easy to explain. When you're talking about the private insurance markets, each state was different, the small group was different from the individual, and so many changes happen, and there's no one-size-fits-all explanation for what happened across the country. So next, I want to introduce Karen Nelson and turn to her to talk a bit about Medicaid. But before I do that, I want to take a little bit of a step back. I didn't think we'd get Karen up to Baltimore without the promise of third baseline tickets, because she's a huge baseball fan, and she said she'd never be on a panel, so I'm taking advantage of this situation. So who here has been to one of our earlier Centennial Policy Scholar talks? Raise your hand if you've been to any of them. Yeah, that's great. Well, as you know, it's been really fabulous to have Congressman Waxman here, and he'll be able to speak in a minute. And I think you've met a number of his former staff. I was just there for a teeny period of time, but you've met people like Tim Westmoreland, who worked for him for a very long time, Bill Core and Bill Schultz, and the tobacco seminar. And I think you get a sense that for any member of Congress, what they do, their staff is so important. And for legendary members of Congress, what they do is even more important. And for someone like Congressman Waxman, it's unbelievable how important the staff are. And nobody exemplifies that on health like Karen Nelson. And working with her was the feeling of being like a JV basketball player getting tutored by Michael Jordan and Larry Bird. That's how I felt the very first meeting I went to from there. And it's not just her encyclopedic knowledge, and it's not just her incredible judgment, but it is the amazing passion that she brought to the job that was inspiring to the younger staff members. And I think to everyone who worked with her. And Karen is really in a class by herself for people who know Congressman Waxman's staff for all that she did. So I'm taking advantage of this to thank Karen, because I think it may take third baseline tickets to get her back up to Baltimore. But Karen, with that in mind, Karen's passion was always around Medicaid and the disenfranchised and the poor, and getting their needs treated with dignity. And for many decades working for Congressman Waxman, she had so many different kinds of victories. And so I'd like for her to talk about Medicaid in the context of the Affordable Care Act. Karen.
Well, do I have to say anything after that? Thank you,
downhill
Josh.
from there.
It's downhill. I don't know about the Michael Jordan analogy, but if you use a sports analogy,
I should have said
you
Cal
always know
Ripken.
you're a really good coach if you've got really, really, really good players, and we really had a terrific staff. And if you have, I guess they call it an owner. I didn't quite get the owner, but good person to work for and good people to have working for you. So that makes all the difference. I do want to talk a little bit about Medicaid in the context of the Affordable Care Act, partly because it's something that almost nobody pays any attention to. You know, when you talk about the Affordable Care Act, very few people would say, and really a major thing they did was the expansion of Medicaid. But that expansion of Medicaid was extremely important. And if you look at the charts, as you just saw from David, he kind of went over it quickly because everybody does. More people came on because of Medicaid than came on because of all the market reforms and all the tax subsidies and everything else that's had attention. And it's just natural. People all look at it and say, oh yeah, there's the Medicaid number. And that number is in fact smaller than it would have been if we did not have the decision by the Supreme Court that's giving to states 100% of the cost of covering people in their states when they expanded was something they had to do. Somehow the courts decided that that was being coercing the states in a way that wasn't legal. So the decision was left to them whether they would decide to come in and take that 100% federal financing to put people in their states, been uninsured, on the program. 32 states said yes. When you look at the states that said no, most of those states were led by people, Republicans, who opposed the act in the Congress and elsewhere from the beginning, and were simply determined not to take the money that was held out to them on the table. The most famous and difficult states now, because they're so big, Texas, Florida, Georgia, filled with people, filled with people who need coverage, having a healthcare system where the providers were begging the states to do this so that they could have that support, and yet they haven't taken that action. I think one of the things that makes Governor Kasich stand out is, despite his political beliefs, he did come from the budget committee. He looked around and said, that's an awful lot of money to leave on the table. So they actually expanded there, but it's relatively rare. But let's go back just a second, because Medicaid, before any of you were born, was passed in 1965 along with Medicare. Again, everybody remembers Medicare. Medicaid's kind of a secondary comment. It was a sort of a secondary thing when they did it. Nobody paid a whole lot of attention to it. It was mostly done to help states who were spending to provide really nursing home care to their citizens, and they needed some federal help. And somebody had the foresight to say, well, if you're going to get money for that, you ought to be covering at least mothers and kids, give them some sort of coverage. And so that's kind of how the program came into being. It was state-directed, always with a very significant federal contribution, always at least 50%, usually in many states more. And states provided basic health care services to low-income people. Originally, only people who were tied to the welfare system. You had to be getting some kind of a welfare benefit. But over time, probably about halfway through, about the time Henry was there, we started to break that link and start to say, you know what, this is supposed to be a program for people who can't afford health care. Let's take out some of these barriers that you have to have a single mother with kids, or you have to do this, and just say, if you're in need, put people on. We weren't perfect with that until we get to the Affordable Care Act, because we did not cover single childless adults, never were eligible for Medicaid. Didn't matter how poor you were, didn't matter if you had health insurance, didn't matter what your situation was. Now, many of you, since you come out of the public health world and you've had a long session on AIDS and HIV, will know that Medicaid, in fact, was the program that kind of stepped up and took care of an awful lot of people that ended up with AIDS. The only place out there that was really doing it. And the way they got there was not covering them as single adults. You had to wait till people were disabled. Once you were disabled, you got onto Medicaid. And again, Medicaid has been the one program we've got that really cares for the disabled. What about Medicare? You say, well, it's true, they cover the disabled. 2 years after you're disabled, you can come onto Medicare. So you have a whole long period of time when you're completely without, most of the people aren't working, don't have employer coverage, didn't have any coverage with Medicaid. So Medicaid was a program that developed over time. You might say almost filling in a lot of gaps in the healthcare system and the way it worked. It stepped up for AIDS. It ends up, I think, the figures are probably even higher now, more than 40% of the births in this country are paid for by Medicaid. It's a pretty significant figure. Over 30 million kids are on Medicaid. Half of the long-term care in the country is paid for by Medicaid. So it's developed into a program that reached into a lot of places. I like to laugh now and say the Medicare people, Medicaid covers more people in this country than Medicare does right now. Doesn't spend quite as much. Doesn't in some ways have the same influence on the healthcare system, because Medicare is run through a lot of federal policies that determine this is how we'll pay hospitals, this is how we'll pay doctors, this is what we'll do. So they can have a more direct influence on the system. States come along and do it on their own and set their own system, so it doesn't get quite that same attention. I'd like to say that Medicare itself could not have continued to exist and been successful if Medicaid hadn't been there to back it up. And the whole really important thing that Medicaid did was to help people who couldn't afford it get their Medicare benefits. A lot of people couldn't afford Medicare Part B, had any of the physicians sign on Medicare, if they didn't have help through the Medicaid program to pay their premiums and cost sharing, but particularly their premiums to get them in the door. Medicaid also wrapped around, of course, with long-term care services that Medicare was always perceived as providing, but really didn't. But if you look at that situation about the importance of Medicaid filling in on the Medicare side because it costs too much, it's just a little picture of what happened when we started with the Affordable Care Act and why Medicaid has ended up such a big piece of the Affordable Care Act. Again, I think if you step back, whether you believe in or wish you could have had single payer or public option or any of the other things, very few people would have said when you stepped into this, okay, and let's make sure Medicaid's a big piece of this. People sort of had a concept that once we finally got to a universal coverage program, you wouldn't really have to have a program that was built on programs for the poor. And interestingly enough, and Henry could tell you about a lot of these stories, but as we worked our way through this, some of the strongest supporters of Medicaid in the Congress said over and over, do we have to keep Medicaid here? Do we have to keep building on Medicaid? Can't we just make everybody all be the same now? So they're all part of the same system. So you don't have a thing that says this is a poor people's program. And every time you came smack into the reality that whatever system we were going to set up, we were never going to have enough money to put the kind of subsidies in there that you could actually make sure poor people could access the system. The tax subsidies, we spend a lot on them, not as much as we would have liked in the House, but we spend a lot on them, but they were never going to be good enough to take care of people down at 150, 130, 100% of poverty. They just weren't. And a lot of the benefits, the preventive benefits, we finally got that into the Affordable Care Act, but a lot of those things that you could get in Medicaid, you couldn't get elsewhere. And so in the end, first step had to be to say, well, we certainly can't undo the Medicaid we've got. And now, because we'd be taking too many benefits away from people. And now what are we going to do about how much higher up the income scale are we going to go? The House, interestingly enough, went up to 150% of poverty. And we had better subsidies once you get onto the market. The Senate both had lower level. They were at 100 when we started into conference. And I'd have to say, if you look fairly at the administration, they didn't really want Medicaid to be the hallmark of this program either. Partly, I think, because they thought politically it made it very difficult to sell it. So they really wanted the Medicaid thing stayed much lower. But as we went through the whole conference and trying to put together a bill, trying to live within the amount of money we could spend and reasonably get it through, turned out Medicaid cost less than putting people into private plans. So every time you move the Medicaid coverage up a few percentage points, you were actually saving some money because you're going to put people in the Medicaid system and not elsewhere. That's both good and bad when you think about it. It's good in the sense that it sort of reflected the same thing we had with the public program, the public option if we were going to have it. You can deliver care more efficiently if you're going through a lot of these public systems. On the other hand, Medicaid also spent less because they don't pay their providers as well, because they're more restricted sometimes in access. There was always a balance there. So we took a program that we knew didn't operate perfectly, that's for sure. But in the end, what it did bring to the table was so important in assuring that people got care, particularly if they were vulnerable citizens down at the low income, that it became a very important part of that puzzle.
Great. Thank you very much. It sort of proves my memory that it's impossible to hear from Karen Nelson on any health policy topic, no matter how many times you've already been over it without learning something new. So thank you very much. So I will turn to Congressman Waxman first to see whether I got it right about Karen.
Absolutely.
Okay. But second, to talk with your perspective, coming into Congress in 1974, leaving 40 years later, where does the Affordable Care Act fit into your sense of what the Congress accomplished for health? And how do you feel about it 6 years in?
Well, I always felt that we needed a national health program. We needed everybody to have insurance coverage. And I came to Congress committed to that goal. And I looked for the very best staff that I could possibly get. And I've been greatly blessed by having the staff that you see here today and staff that worked for me or the subcommittee or the full committee at the other sessions of the Centennial program. I've learned a lot from them. And I never could have done the job that I did, and I get all the credit for what they actually accomplished. We wanted to cover every American. This was a goal. This is a country that the whole basis of our notions of fairness and equity is that health care should be a right for everybody. And it shouldn't be a health care system for the very wealthy, which is good, and then maybe some kind of system, if there's anything at all, for the lower income, or they're just on their own. But that was pretty much the system we've had in this country for a very long time. When I came to Congress, the leader for health insurance coverage was Senator Kennedy. And earlier we were on the program talking about this issue on a video that I think you'll have access to if you haven't seen already. And it used to be Kennedy Corman and Kennedy Griffith. And at one time, it was Kennedy Waxman, which my mother always said was the Waxman-Kennedy bill. But the idea is it'd be a single-payer health insurance system akin to Medicare for all, very much like every other industrial country in the world. But our efforts were not going to be realized. So when we couldn't do that, we looked for ways to expand coverage. We took the Medicaid program and started to break the link to poverty. At one point, for example, early on in the 80s, we found that a woman could not get access to Medicaid even though she was poor enough. And in some states, you had to be the poorest of the poor. So she was eligible for that program on an economic basis. But if she were pregnant and had not had a child, she was not eligible because she had to be on a welfare program like Aid for Dependent Children, where she didn't have a dependent child. So she had to go through the pregnancy without prenatal care. And I remember talking to Henry Hyde, who was a member of Congress from Illinois, who was the leader of the so-called pro-life forces. And I said, how can you be pro-life and not allow a woman to get prenatal care? And he said, you're absolutely right. And we started expanding the Medicaid program. In some cases, we made certain things mandatory, and we made it optional. And then after it was optional, we made it mandatory. But we covered more and more people because we knew lives were at stake. When we finally got to the Affordable Care Act, President Obama wisely said, we're not going to remake this system. We just don't have the ability to do it. We've built up over the years a system that's heavily financed through a tax system, where most people have their insurance through their jobs. So what we'll do is build on the existing system. That's what the Clinton administration tried to do, but they were much more aggressive in saying that everybody ought to get their insurance through their jobs. Just like we had a minimum wage, we had to have a minimum health insurance benefit. But President Obama looked at it and said, I could like a single-payer Medicare for all, but that's not going to happen. Let's work off the existing system and cover people who couldn't get insurance primarily because their employers didn't offer it. And if they went to the individual market, they couldn't buy it because insurance companies discriminated against them if they had pre-existing conditions. Or if they couldn't afford it, they just couldn't get it. We said, well, let's give them a tax subsidy to help them pay for it. That was the way to plug in the coverage part of it. And then the Affordable Care Act has a lot of parts to it to try to make the healthcare system, whether it's on Medicare or private employer or the individual policies, have a greater cohesive rationality to it. That we wouldn't allow a private insurance company to have an overhead of more than 15%. We didn't want these bloated overheads when Medicare was only 2%. And we put in the restrictions on that. We put a minimum benefit that was to be decided for all insurance coverage. We built in preventive care. And maybe the most significant part of what we did was to try to reform the healthcare system so that we weren't just paying for quantity, more fee for services, but encouraging affordable care organizations and other ways to manage the care so that it was less expensive and fit in with the needs of the patient. So that was where we came to in the Affordable Care Act. And if you ask people, do you support Obamacare? Overwhelmingly, people say no. If you ask them if they support the Affordable Care Act, there are more people who approve of it. If you ask people, do you approve of each of the elements of it, keeping kids on the policies of the parents till age 26, stopping discrimination by insurance companies, giving tax breaks, you go through each one of those, overwhelming support for it. But there is a disconnect because of a heavy barrage of propaganda that a lot of people are getting benefits they never would have had before, and they don't quite realize it's the Affordable Care Act in operation. Very much akin to the people that came up to us while this bill was pending and said, I don't want a government-run health insurance system. Leave my Medicare alone, ignoring the fact that Medicare was a government-run health insurance system. So I think that it's a great accomplishment, but it's not the end, because there's a lot to build on, there's a lot to correct, and a lot to learn from the system that's now put into place.
Great, thank you. I wanted to ask Dr. Blumenthal, since you've written a book on presidents and health policy, maybe to reflect on what Congressman Waxman said about the role the president played, and certainly how important that was to getting it passed, whether the program's identification with him as, how that fits into the politics and what that means for after he leaves office.
Well, thank you, and thanks to my colleagues for great remarks. The history of health insurance in the United States is really the history of politics in the United States and the history of the evolution of our social systems. In the case of healthcare, one of the absolute essentials to making healthcare coverage a political issue has been presidential advocacy. The President of the United States is the only elected official in our government anywhere who is elected by all the people. And though Congress is an equal branch of government, when it comes to summoning the political will to do something hard, if a president is not all in, that something cannot happen. And that has been proven time and time again. So it was by no means assured when the president took office, even though he had advocated universal coverage during his campaign. It was by no means assured that he would stay behind it. And having written a book about how presidents manage healthcare and having just started working in his administration, I was intensely interested to see whether he would stand behind that, because presidents don't always honor their promises, and there were many reasons at the beginning of his administration for him to push that particular promise aside. We forget that in 2008, the United States was on the brink of a huge financial catastrophe, and the president had his hands absolutely full trying to deal with that. It's my understanding that his economic advisors, maybe Michael can talk to this, were pretty unanimously opposed to going forward with his health insurance proposal, and that it was his personal decision to continue along those lines. And that is a incredibly courageous thing for any president to do under any circumstances, but particularly under the circumstances that existed in 2008. And as Congressman Waxman has talked in a previous session we had about how important it was that the president stayed with that, and it was indeed absolutely important. He could not make it happen, but he could make it not happen. One of the things he did, though, that was extremely important in a historical context, having just said what I said, one of the important things he did was to back away from the details of the law when it was actually being written. He made clear what his principles were, but he left the drafting to the House and the Senate. That was a very, very important thing to have done. It's not widely appreciated that Lyndon Johnson did the same thing during Medicare and Medicaid. There are tapes of him talking with Wilbur Mills, who was the critical chair of the House Ways and Means Committee, where he said directly to him, "Wilbur, I don't care what the details are. We'll call it the Mills bill. Just get it done." And Johnson, as a creature of the Congress, understood that he needed to have the Congress own legislation of that magnitude and importance to have the loyalty and support of the many factions in the Congress in order to make that happen. And I think one of the keys to the success of this particular effort, and though it may seem modest to some, it was a Herculean task to accomplish politically. One of the keys to the success was the decision to let the Congress take the lead in drafting the legislation. It should be called Congressacare, not Obamacare. But the president gets the credit. He also gets the blame, by the way, if it doesn't pass. So I think those were really important from an historical standpoint, decisions. There are other things he did, one of which was to agree with the leaders of the House and the Senate, Nancy Pelosi and Harry Reid, to revive the law after Senator Kennedy passed away and his replacement was a Republican, and he had lost his veto-proof majority in the Congress, and to go through the maneuvers, which I don't fully understand, but the congressman and Karen and others can instruct you on, but to go through and not give up at that point was also an act of courage. So he didn't write it, his staff didn't write it, the Congress wrote it, but his leadership was pivotal at many points along the way.
I just want to make one comment about that, because having watched some of the history here, when the Clinton administration came in and pushed health reform, they had a pretty similar approach, differences certainly, but pretty similar. But they wrote the law that they proposed to the Congress, and they went into every detail. When they came up and briefed the congressional staff on it, it was sort of like, we've thought this all through. This is the way it's going to be. It's highly complex, as all legislation is, hard to follow. And they sort of totally skipped over the step of a political process where you get members of Congress involved in understanding things. You can't just sort of hand them a thing and say, this is it, we thought it all through, go ahead and vote for it. They didn't vote for it. We could never even get it out of our committee. So I think President Obama learned a real lesson from this and said, let's let the Congress develop that. And it's true, we really only had a relatively brief set of principles that he laid out, an overall approach. Now, that's not to say that they weren't heavily involved every step of the way. We had constant meetings. We constantly met with the staff up there. We constantly were meeting with the Senate. Everybody was going through their different approaches, putting things together. And just in the House side, we had 3 major committees that hadn't always worked so well together in the past. We actually all worked together to develop what the legislation was going to look like in the House. But even then, what could pass the Ways and Means Committee, when we went to Energy and Commerce, we couldn't say to our members, can't change that because we agreed with the other committees, this is the way it's going to be. They wanted to have input too, so you got coming out of each of the committees slightly different approaches. Then you had to put that together for the House floor. Then you had to go back and go through this complicated process with the Senate. The real difficulty that presented, that I think has haunted the program ever since, is that you never could give a simple answer to the question, what does President Obama's plan do on this, that, or the other? Because the answer was, well, the House Energy and Commerce bill did this, and the House Ways and Means bill did that, and actually the Senate Labor bill does something a little different, and Finance has taken a slightly different approach. And then the bill we're taking to the House floor is going to be a little bit different from the rest of them. They were all sort of details, and important details, but you never really could stand up there and say, this is what this is what I'm pushing for. So I won't forget the first time Secretary Sebelius came up and testified before our committee. We were already well on the way with the bill, and the Republicans grilled her over various aspects of the bill, and her answer was, this isn't the president's proposal. You'll have to ask the members of the committee. He felt kind of bad for her. She was new there. It wasn't that she was backing away, but she didn't have ownership on it. So that, the very famous and really unfortunate and very unfair remark where Republicans like to cite when Speaker Pelosi said, people are going to have to see this bill to know what's in it, really meant when people see these benefits and really get them and know them, they're going to appreciate this. Not that we didn't have any idea what was in the bill, but it is true the American public didn't have a super clear idea of what all those details in the bill. Not that they maybe ever would with a 1,000-page bill, but they would have had a much clearer idea if there had been one plan that the president kept pushing. The only thing is, we probably wouldn't have been able to pass it. So there you go. You get something good on one side and lose something on the other. But it was very confusing. And the other thing is, and David sort of referred to this, with the death of Senator Kennedy, the Senate could not pass a health insurance bill again. And that was what we were dealing with. They essentially said, we don't have the votes anymore to repass that bill. You must take this Senate bill as it stands. The House had theoretically enough votes, so we had a bigger majority. It came down to, I think, one vote to get it through. But in essence, they said for all of its deficiencies, and Lord knows there were some, it was a more conservative bill than the House bill, had a lot of drafting deficiencies because they'd had in a very short time period to put together two complicated bills. Things that usually get worked out in conference couldn't get worked out. Just said you had to do it. And then we had to look for this other process, the so-called reconciliation process, where you had a protected procedure under the Budget Act to take bills through with a simple majority. It got around the Senate 60-vote thing. And where we could use that process to make changes, and they all had to be tied to budgeting, we put through some improvements in it or changes in it. But you're very limited in what you could do. You couldn't put together a simple bill. But that's how close it was, really, in terms of trying to enact it.
All right, Karen Davis.
Well, these are great remarks and great insights to share with all of us. And I think, obviously, President Obama's administration learned from some of the failures of President Clinton, or I must say, since I was in charge of President Carter's plans, from some of our problems as well, where, again, I think the attitude of the president was, I've developed the great plan. I'm an engineer. I don't have to sell it to the Congress or to the public. And so others tried to build on that. But as an economist, the way I always thought about it is you had 85% of the people who were covered. They had health insurance. Might be from Medicare as seniors, or it might be from employers if they had a good job. It might even be some low-income people with Medicaid. But the goal was to cover the other 15%. And certainly I thought the failure of the Clinton plan, and probably a little different with Carter, but the Clinton plan, was that the 85% perceived they were going to have to pay to cover the 15%. And furthermore, they might not be able to keep the insurance they had now, or they might not even be able to keep the doctor that they had now. There might not be enough doctor capacity to go around. So you had to have in the Obama legislation something that made the 85% feel that they were getting something out of this. And so while everybody focuses on Medicaid, the marketplaces, the expansion of coverage, a lot of it was also in there to improve primary care, to improve prevention, resources for public health, and to really change our healthcare system so that everybody would have higher quality care. There would be fewer infections acquired in hospitals, fewer readmissions. We would really get serious about transforming the delivery of care to have a high-performing health system that delivered more value for everyone. So I think that helped. Maybe it didn't swing the whole thing, but it helped make it more than just about covering the uninsured, to making better care available for everyone.
And I would add that just the extending kids up to 26, which got implemented early, had a pretty big impact very quickly on people's perception
Absolutely.
of the law.
And I was just going to add to what Karen just went through to say that another feature of that really addressed the concerns and wants of the 85% was an employer requirement that they offer minimum value affordable coverage to their workers if they employed more than 50 full-time workers. So instead of having one answer to the possible erosion of employment-based coverage, which was always an argument against doing what we were doing, because the other side of the aisle kept saying, when you do this, you know, the employers are just going to get out of the business. And actually, this requirement, so-called the employer responsibility requirement, said you either offer affordable minimum value coverage or you pay for the cost of your people who go into coverage through the individual marketplace. So that was another piece of this that was intended to stabilize what had been a declining amount of employment-based coverage after the enactment of the Affordable Care Act.
Sure. Dr. Blumenthal, and then please come to the microphone if you have a question. We'll go to audience questions.
So building on Mike's comment, one misperception about the law is that it was a so-called government takeover of insurance. In fact, it was a law intended to rescue and support the private insurance industry and to make it sustainable into the future. And actually, critiques of the law sort of go back and forth between accusing it of being a government takeover and then also accusing it of being a bailout of the private insurance industry. And you hear people make those same points.
Right, sometimes in the same tweet.
That's right. But really what it represented, and this is, I think, at the heart of its critique from the left, is it embraced and supported and put foundations under private insurance and assured that private insurance, with all its positives and negatives, would continue to be at the heart of American healthcare coverage. That's what the exchanges or marketplaces are about. It's what the subsidies of the purchase of private insurance is about. It's a recognition, a political recognition that 85% of Americans who were insured through the private insurance sector would not be supportive of an effort to change the status quo, and that to get to the other 15%, you had to make them secure. And I think that's what we're living with right now. And a lot of the things that the law is criticized right now are things that are attributes of a private insurance market, which the law had to embrace in order to insure the other 15%.
Great. You introduce yourself.
Sure. Hi, my name is Maya Zoom. I'm a postdoc here at the School of Public Health in the Department of Epidemiology. I was curious for anyone on the panel if you had insight in regards to the phasing out of the DISH payments and how that has affected safety net and small rural hospitals, because there seems to be less of a conversation about the impacts, in particular to states that haven't expanded, such as Mississippi or North Carolina. So is there any hope other than, well, we hope the states will expand and take provisions from the Affordable Care Act? Is there something happening on a federal or state level in regards to addressing the adverse effects on those hospitals? Thank you.
It's a great question. Who's up for that one?
I'll take a quick stab. I'm not aware that there is something moving to address that situation, but you're right to point out that in the absence of states in particular who did not take up the opportunity to expand Medicaid, that it really put increased pressure onto many of the healthcare providers, particularly small rural hospitals, because the coverage that they were looking for in their communities was not materializing. At the same time, it's important to remember that even though the Medicaid expansion coverage goes up to 138% of federal poverty line, any household with incomes above 100% can actually access and purchase with subsidies private health insurance. So to the extent that that's happened, that's been helpful to those institutions that were looking for a more covered population in their service area. However, of course, there is this terrible problem of individual families and individuals below poverty and above whatever the state's very often very low Medicaid eligibility requirement is. And those people have no options, just as they had before the Affordable Care Act. And many of those people, of course, find themselves in the service area of some of those very hospitals. But the one other thing I'd say about this is that I do think there's been some moderation in the schedule for the reduction of the DISH payments to reflect that the coverage assumptions that were underlying those cuts in the DISH payments have not been fulfilled, and therefore we shouldn't be taking away the money quite as rapidly as was, because as you probably know, they weren't, all the money didn't come out the first year. It's phased in over a number of years, and I think looking forward, there may be still opportunities to address that scheduled implementation to reflect the financial challenges of these small hospitals that are having difficulty staying in business.
You know, from my perspective, the DISH issue, disproportionate share hospital payments, symbolizes that the Affordable Care Act was trying to do more than just support safety net institutions. They wanted to make people healthier. And so payments that are like essentially cash transfers to hospitals to take care of people after they've had strokes and heart attacks aren't going to be as well organized as payments that go for insurance that can allow people to get primary care and avoid having those strokes and heart attacks. And so you've got this tension when a state is refusing to expand Medicaid because people act like the DISH payment is payment for health. It's really payment for the institution, and which has an indirect relationship for health. And structuring that payment differently so that people can stay healthy is a really important goal for public health. It's one of the reasons I think that there's lower life expectancy in rural areas, for example, is because there's so little attention paid to health. And if you're just focused on the health of the institution alone, you miss that. And so the administration has this difficult balance, because if you make it so easy, you may be making it easier for them not to create a system that produces health. So I find it a very difficult dilemma, which is why it was a great question, why you had so many howevers in your answer, because you're going back and forth. Anyone else want to comment, or we'll go to Adam? You want to introduce yourself?
So my name is Adam Limehouse. I'm a Master of Public Policy student focused in health, finance, and economics. And I'd like to ask just a structural question to our distinguished board. As the various fixes to the Cadillac tax move their way through the House and the Senate, especially in terms of the actuarial value safe harbor that's currently before the House, Congressman Waxman's old committee. What fixes would y'all propose for those areas in the country that have disproportionately high health insurance premiums in both markets, while maintaining the downward pressure that the Cadillac tax was meant to impose on those premiums?
Right. These are not softballs between DISH and
Yeah,
Cadillac tax. You're not getting any softballs.
It's interesting, the two questions we've had are quite in the weeds, and and there may be an audience watching this on television that it will go right over their heads. For example, the disproportionate share was adopted to indicate that there's an institution has a disproportionate share of uninsured people, underinsured or uninsured, and therefore we try to build in a little extra in the reimbursement, because those institutions are going to lose money if they provide care for people who don't have insurance coverage. And the phasing out of that was the idea we'll have more people insured, so we won't need the DISH, but that extra payment serves a different purpose. The Cadillac tax, however, was a mechanism to try to hold down the cost of health care by saying that if you have employer-based coverage, it can't be so lavish that we're overpaying through the tax system for you to have it. So you would have to pay a tax in order to have that Cadillac amount of coverage. That was why President Obama supported it. Many economists argue that if you correct that kind of extra benefit for the upper income, it will help lower health care costs overall. That's a controversial statement, and a lot of people are concerned about it. I think that the Cadillac tax might have been eliminated, except for two reasons. One, you have to come up with the money to pay for it. And the other is, I don't think President Obama wanted to sign that. So they kicked it over for a couple of years till we get the next president, and the issue will be revisited as to that particular issue. But it was a way to take away insurance that was too generous. Because if the insurance is too generous and people pay less out of pocket, they may overuse the healthcare system, and we didn't want that to happen.
And of course, that was because we pay for that care, if you will, through the tax deduction to business and indirect tax payment for it. That's what was seen there. So people thought we should be equalizing. Instead of spending indirectly taxes on that, we should be spending more directly on getting health care to people who most need it. Having said that, however, as with everything else in the healthcare system, there was already a developed system there, and people don't really like losing what they had. They don't perceive it as somehow the government paying taxes for it, even though that's the way it works. Secondly, though, it also demonstrated our tax system is not able to be very sensitive to differences in area with differences in healthcare costs. That's, again, just a given. It doesn't work so well that way, and it's very, you can't really adjust the tax system to say, well, you get a bigger deduction if you're out there with this kind of higher healthcare cost there. So there was some attempt to write in, Mike would remember some of the details better than I do about trying to write in some things that would be sensitive to that in terms of how it would work. But still, it's very hard to be fully reflected.
Not to be too weedy about it, but there are, in the law now, are some bases for making adjustments to the cap that the Cadillac tax imposes on employment-based coverage. I think some people would say, going forward, this is something that maybe needs to be looked at in terms of agenda for improvements in the Affordable Care Act, because of these particular exceptions, if you will, or basis for adjustments, in some people's judgment, don't really reflect some of the differences that drive higher health care costs in one community rather than in another, and that you shouldn't penalize the people getting insurance coverage in that community just because health care costs are particularly high there. I don't know whether that is an adequate answer to the question, but I think people are looking to find some other adjustments to that Cadillac tax limit that would also reflect higher health care costs in different types of communities.
Great. Karen, did you want a quick?
Well, I've never been a fan of the Cadillac tax, and I always tell my economist friends about why the thinking on it is flawed. First of all, we all believe in research. The Commonwealth Fund published a study showing that the correlation between the generosity of the benefits and the premiums is about 0.02. So logically, you think if the premium is higher, it must be because they're covering lots of frill services, executive fitness tests, etc. But in fact, what determines the level of the premium is how old the people are who are covered, how sick the people are, as Karen says, where they live, and how high the costs are. In fact, the insurance company may have been trying to drive people out of this plan because they were a sick group by jacking up the premiums by 50% every year until everybody had to leave the plan. So to me, it would, and even they we economists throw around terms called regressive, progressive, but the definition of that is the tax break is a percent of income. And so the old code of not counting employer-provided benefits as taxable income to the individual. Yes, the dollar amount may have been more for higher income people, but it was trivial as a percent of income. So really who the old code was helping were more as kind of a U-shape, but at the middle class working family between about 40,000 and 60,000. But what I think at the bottom line is we have a system for saying these are good plans and those that meet the standards of the bronze, silver, gold, and platinum, whether I like all of the features of the bronze and silver or not. But if a plan is a gold plan or a platinum plan and we would approve it through the marketplaces, then why would we impose a tax on anyone that buys such a plan or gets such a plan from their employer? So rather than set a dollar amount that if the premium is above this level, say if the benefits go beyond plans that are provided through the exchanges, then maybe that's excessively generous coverage and there ought to be some disincentive for it.
Right. Fortunately, we have a 6-hour seminar tomorrow on the Cadillac tax. Webcast. All right, I'm going to go to Marley for a quick question.
Hi, I'm Marley Ikowitz, and I'm a Master's of Public Health student. And first, I just want to thank you for your tremendous work and for your remarks today. I'm curious, going back to your slide, Dr. Blumenthal, thank you, on the 20 million that are still uninsured and the number of people who are eligible for coverage under the Affordable Care Act, but that we're not reaching. What are some of the strategies? What are some of the reasons for that? Continued lack of coverage, what are some of the strategies to address that? And in particular, I'm curious about your assessment of Secretary Clinton's proposal, whether the $500 million a year will be, in terms of outreach, will go far enough, and whether the kind of push towards value over volume will actually not reach the people who are most in need of the coverage, because we'll sort of push to have people who are healthier. The plans will push to have people who are healthier in their coverage.
Right. Or another way of saying that is, it going to be another 80 years before we get to the other 20 million, or what's going to happen?
A lot of questions, a lot of good questions. So why are there still so many people eligible for benefits who aren't taking advantage of them? There are a lot of reasons. A lot of people just don't know. It's amazing how many people don't know that they could get those benefits if they apply for them. It's amazing how many people didn't know they were eligible for Medicaid, who are among those 14 million who have gotten Medicaid. They actually, some of them got Medicaid under the old qualifications and didn't know they were eligible. So Medicaid is expanded even in states where the states have not expanded the eligibility because of the fact that people went to the marketplaces and to see if they could get private insurance, and they were told, well, you're eligible for Medicaid, and we're enrolled in Medicaid. So lack of knowledge. Complicating that is language barriers. So a disproportionate number of the uninsured in the United States are Spanish speaking or have another first language other than English. So that's a particularly hard population to reach. One of the reasons California has been so successful in enrolling many millions of people in their plans has been that they've very aggressively gone after Hispanic populations. So lack of information is still highly prevalent. There are a number of states that are affirmatively opposed to recruiting people into the marketplaces. And so it's been hard in those states, to get public advocacy and public support of informational campaigns. One of the most powerful ways of enrolling people successfully, according to our work, is to actually have a personal assistant help people enroll. So once people get to the marketplace, it can be very confusing online to figure out what you're eligible for, what you're not. If you have someone actually coaching you at your side, you're much more likely to make a choice and enroll having gone to a marketplace. So that's one reason why spending the kind of money that Secretary Clinton is talking about could be successful. Is $500 million enough? I have no idea. It's better, if you want to enroll more people, it's better than not spending the money. And it will be especially valuable in the states that have chosen, for whatever reason, not to promote enrollment themselves. and those tend to be the non-expansion states. And so I think you wouldn't necessarily spend that $500 million equally in all the states. It wouldn't be as important in California, though I'm not sure that Congressman Waxman's home state would agree with that. But if you were looking for bang for the buck, you'd probably spend it in Florida and Texas rather than California. Is this law going to get to 100% coverage? No, it's not. The CBO has never projected that it would, even if Medicaid had been expanded as predicted. Almost all the experiments that have been done over time with expanding insurance through subsidies have been unable to enroll all the populations. And there are some people who just will choose not to enroll and to pay the penalty now associated with not enrolling for whatever reason. Sometimes it's an ideological statement, sometimes it's a cost-benefit calculation about whether they're going to need insurance or not. And there will always be some people who don't know. That's the kind of, we are a very big country with a very diverse population, and the kinds of incentives, the mandate is not really a mandate, it's an incentive system to purchase insurance. It will never be sufficient, I think, to overcome the resistance of all Americans to getting health insurance. I don't think value-based payment is a threat as long as risk adjustment is effectively enforced. Now, that also is not going to be perfect, but it's not, in my view, anywhere near as important a problem as ignorance and lack and resistance, political resistance to enrollment.
Great. I want to maybe ask Adam and Katie to both ask your questions back to back, and then we'll wrap up.
Sure. I guess I'll make it quick. I'm a second-year master's student in public policy, and I remember 6 years ago when I heard about the ACA, I was skeptical. I thought it would decrease innovation, but through the past 6 years, and especially my studies here, found how great it is for innovation, especially things like the MLR, medical loss ratio that you guys mentioned. But Medicaid managed care is exempt from the medical loss ratio, and I think only a few states have enacted it for their managed care plans. Do you see that as a large problem or something that has to be done in order to make sure this type of insurance reform is spread to private managed care companies?
Great. And Katie?
I'm Katie Rubinger, and I'm an MPH candidate here. I don't want to be redundant, but similar issues in terms of Medicaid and the lost potential when the Supreme Court struck down that mandate. And so I'm just wondering, sort of piggybacking on Marley's question, what's next for Medicaid? Is it a national fix? Is it a state-by-state type of issue? And I would love to hear your opinions on that.
Karen, do you?
Well, first, we have to decide who's going to be president. Second, it would be nice if we could know who was going to control the Congress. We face such a really unusual situation with this law that we've gone so many years without there being ever an opportunity to make the most sensible adjustments to it because it's so politically charged. Nothing can happen. About maybe the only thing that could happen is we'll find our way to take, the tax off the medical device companies or somebody who are such powerful lobbyists that they'll cross the lines and do it and get it through, but nothing in a positive way about fixing it. And it certainly isn't going to change if we don't have it might change in a very bad way if we don't have a Democrat in the White House, because we'll start to see some of these really bad bills maybe make their way through the Congress and not have the protection of a veto. But the Congress has to finally take the attitude that this is here, and now we better figure out how to do some fixing before that happens. Having said all of that, under almost any circumstance, the best of circumstances, it was always hard to make big adjustments in Medicaid that spent a lot of money on the Medicaid program. Now, we assumed we'd be spending 100% on these Medicaid programs at the state thing. It still boggles the mind that somehow that was coercing the states to say, take all of our money. So I don't know exactly how that adjustment would be made if we had a surprising wave and really completely controlled the Congress. But I do think we would probably offer a federally run option for those people would be if you know, you could write the law without having to worry about passing it. And to take care of them in those states so that they just couldn't say no to that whole set of their population.
Just quickly, I don't know if Karen would agree with this, but some people theorize that if you did what actually the President Obama's budget now proposes and what Secretary Clinton has also proposed, which is extend this generous financing opportunity to any state for the 3-year time from the time they actually agree to expansion, that it might work much as happened with the CHIP program, which some of you, if you've studied this, you know when it was enacted, it also was a state option. And of course, all the states didn't come into the CHIP program initially, but over, I think, maybe 5 years or so, all 50 states were in. And many have, some, I shouldn't say many, some have theorized that once we get past this election, that states might feel less political opposition to taking advantage of the generous coverage and do something and actually expand the program, and that this would be enhanced if they could also get the same deal as the states who came in initially and got 3 years of 100% financing. So that's a possibility, but only, as Karen points out, that depends heavily on who gets elected in the Congress and for the White House. So.
Great.
But
I
we
think-
should ask
Yeah.
you for your argument.
And I think HHS, we will. HHS has proposed extending the MLR
Right.
to managed care
Yes.
plans, so we'll see how that plays out. So as we're wrapping up, I wanted to turn to Congressman Waxman, as you have talked at some of these other seminars about taking the long view on legislation. What do you think the long view of the Affordable Care Act is 6 years in?
Well, 6 years since we enacted it, and now it's in effect. We've had a bumpy road, especially rolling out the plan so people could enroll and understand what they're getting. Now I think people are seeing the benefits, but they're also seeing some of the difficulties of the law. There's no end point where you have anything that you could say needs no change, needs no more work. We're going to learn a lot more while this law is in place. I'm optimistic about the election. I think we're going to have President Hillary Clinton and perhaps a Democratic Senate. That doesn't mean a lot if you don't have 60% or 60 votes in the Senate. But you never know. It could be that the people will decide maybe the filibuster is not so significant because it's been more of a barrier than a help in accomplishing the job that senators should be doing. But I think that once we're past this administration, a lot of people will look at the issue anew with a different perspective and with a status quo that they may not have wanted, but one that they will accept and decide to work off. I can't imagine, even if we had a Republican president, that this law would be repealed. It would be so harmful to so many people that I think that I think a lot of members of Congress would decide that they're going to be punished, as they should be, for doing anything like that. But if the Republicans win the presidency, they could figure that they're always going to be rewarded now, no matter how irresponsible they act. So, but I don't believe that. That's not the history of this country. We'll build on this. We'll keep on working, and that's why it's so important that the students that are here not just know the general framework, but understand some of the very specific issues, because even the narrow, in-the-weeds questions have real significant impact on people's lives. So thank you for all of you to sponsoring this forum, and I think it's a very important one. And I think the 6th anniversary of the Affordable Care Act is an occasion to celebrate.
Yeah. Great. Well, please join me in thanking the panelists.